Villeneuve. We go now to the Canadian Cardiovascular Society, Dr. Paul Dorian. 10 minutes, please.
Merci beaucoup, Monsieur le Président, et bonjour à toutes et à tous.
Sure. Welcome, everybody. I would like to first of all thank all the members of the committee for the opportunity to represent the Canadian Cardiology Association. We are pleased to have this opportunity to take up some challenges concerning some patients suffering with heart disease during this COVID-19 period and coming up with solutions.
Representing the Canadian Cardiovascular Society, our 2,500 members include cardiologists, cardiac surgeons, and scientists. We provide specialized and ongoing care for close to 3 million Canadians living with heart disease, and we're very grateful for this opportunity to present to the committee. What I'd like to do first is to describe the consequences of the pandemic on heart patients, and then suggest some recommendations to help improve patient care in the short term, as the first wave of the pandemic unfolds, and in the future as subsequent waves of this or other infections hit. At the front line, what we're observing is that sick people are not seeking the care that they should. You've just heard that a moment ago. When the COVID pandemic struck in Canada, we were quick as a community to enact strict measures to contain its spread, including widespread stay-at-home messaging. Canadians have been very good at listening and adhering to this advice. So much so that we've seen a significant reduction in patients seeking emergency care for all illnesses, but particularly for cardiac care. Although the numbers seeking care are way down, heart attacks and other emergencies have not stopped occurring. We believe that our patients perceive hospitals to be overloaded with cases of COVID, of course, correctly or incorrectly, and they're afraid of coming to hospital and being exposed to the virus. As a result, patients with emergency needs are staying at home and waiting to see if symptoms go away, and some, unfortunately, are dying while they wait. When they finally do seek emergency care, they have often delayed so long that their conditions have become more serious and harder to treat. This is something we've observed over the past month or so. The later that patients present for treatment, particularly for heart attacks, the less we can do for them, and we're seeing more complications, which are harder to treat. Secondly, while we deal with COVID patients, wait lists for canceled procedures have skyrocketed. To be ready for an anticipated surge, hospitals have appropriately, we think, reallocated resources and freed up beds. But in our effort to be prepared, hospitals have been operating under capacity. Since March, across Canada, a huge number of planned life-saving procedures were postponed. As an example, as of March 15th in Ontario, there were about 2,000 patients waiting for valve procedures and 450 for defibrillators. As of May 3rd, that waitlist had grown to 2,500 valve cases and 680 defibrillator cases. These waitlists have unfortunately resulted in patients suffering, and indeed, some have died. My colleagues speak of their valve patients who have been accepted for procedures dying at home before the surgery could be done. So we've avoided a surge in COVID patients, but the backlog of heart patients waiting for treatment has surged. Wait times are now longer than they've ever been, in years in some cases. A major complicating factor, we think, in planning for and delivering care has been the lack of real-time data. Without real-time data, we have no way to understand how local health service supply and demand trends, and to make regional comparisons to inform decisions about allocation of services, and to inform our patients about opportunities to seek care. Recently, we've collected some hospital data that there have been drops as great as 40% per month in several provinces since March in the number of patients coming to hospital with a kind of heart attack called STEMI, the most serious type of heart attack. This has been observed in other countries as well. But we don't have all the information needed to interpret what's happening. Were there fewer heart attacks occurring? We think probably not. Did patients delay in calling 911? Did ambulances make fewer and slower trips? Did patients in the field arrive at hospital already deceased? And was care in hospital delayed because of COVID precautions? We unfortunately don't know. It's frustrating to note for us that much of the data to answer these questions exists and is collected already in real time, but is trapped in data collection systems that don't talk to each other technologically, or that prevent data from being shared due to geographic boundaries or for legislative, contractual, or policy reasons. Collectively, these barriers prevent health data from being used for the very reason it's collected, to enable care through evidence-informed decision-making. We must note that our national resource, CIHI, Canadian Institute for Health Information, has responded as best as it can throughout the pandemic to supply data. However, CIHI itself is limited by the same barriers I've just mentioned. In this moment, we need data in days, whereas the typical time frame for obtaining data is months. We're eager to help resolve these challenges brought on by the pandemic. And in looking to contribute solutions, the CCS has several that we would like to propose. First, I think we need to refine public messaging in the face of a pandemic. If we can anticipate that stay-at-home orders result in heart attack victims not seeking or delaying care, public messaging needs to be more precise and widely shared. The federal government, through the Public Health Agency and Health Canada, are well positioned to lead this, and the CCS is willing to help develop and spread these messages. Second, public health officials, health service planners, and care providers need shareable, real-time data. Current information that can easily be shared would enable more nimble actions in an emergency. We would know where and whether scheduled and essential procedures might still take place based on need and in balance with local demands. And with better access and sharing of data, we can reduce the impact of national health crises on cardiac and other patients while still providing crisis-related care to those affected. In the current situation, COVID-19 patients have been appropriately prioritized. The consequences for other patients, unfortunately, have been higher than would have been ideal. Without data, we don't think we can do better next time. Our ask of the government and the colleagues and this committee is to take the lead to improve the sharing of real-time data. This could be done, for example, by forming a national expert working group to oversee coast-to-coast streamlining of data access and sharing. This expert group would work with federal and provincial health data stewards to identify and resolve the long-standing legislative and technical barriers to rapid shareable information. Their mandate would be to enhance coordination by locating all the data sets and getting them to talk to each other. I emphasize this data is already being collected. This committee would also help aggregate data so it could legally and virtually be all in the same place. And through understanding of what's going on locally and comparing to what's happening in other regions or provinces, we can accelerate best care and resource use. In the long run, we think that improved access to data can refine healthcare system delivery. Care can be more equitably available and higher in quality. Care pathways could be more efficient. Virtual care can be deployed in the most effective ways. Low-value care can be identified and reduced. Savings can be reallocated to where resources are needed the most. And if we get this right, we can expect to see better patient outcomes during, but also beyond any crisis. For those of you on the committee,
pour les membres du comité,
you will know that the need for access to high-quality data and national comparative reporting is a call the society has been making for some time, and we are very grateful for the support that we received from our partners and supporters in government. The COVID crisis has shone a light on access to data as a major impediment in responding to a pandemic. Drawing attention to this at the highest possible policy-making level is a key contribution that the CCS aims to make. I'd like to just briefly list the actions that the CCS has already taken to support the pandemic. So thus far, in the last 6 weeks or so, we've developed, published, and shared clinical guidance for health professionals who care for cardiac patients affected by COVID. We've developed and widely shared clear messages stating that people experience chest pain or other signs of heart attack should urgently seek care. And we've done this in partnership with the Heart and Stroke Foundation of Canada and others, but I think we can do more. We've also funded research to learn more about COVID and its effects on patients with heart disease. The CCS will undertake to continue to do all we can to help in this crisis, and I'd like to signal to the committee that we're willing and able to consult and provide guidance on any matter, if we can be of help, concerning Canadians living with heart disease in light of this pandemic. We will all have the most success working together if we align our efforts and support one another. Merci, and thank you for this opportunity, and I look forward to your questions.
Thank you, Dr. Dorian.